delighted to be here in Iowa. I got here late Sunday night. I was here all day yesterday and today, and I've seen some parts of your beautiful state. I've never been to Iowa before, so this has been quite a treat, and it reminds me a lot of Arkansas. Rural farmland. My father was a farmer. He farmed rice and soybeans, and so I was right at home as we were going down the road looking at the soybeans that are getting close to being ready. Not so familiar with corn, but anyway, have really enjoyed the time. And I am going to talk about a program that we started in Arkansas about actually in '01. And it's called the Arkansas Aging Initiative. We are one of 7 programs funded by Arkansas' share of the Master Tobacco Settlement. There were 46 states that, sorry, is that working? Is that better? There were 46 states that joined in the lawsuit against the 3 major tobacco companies, and the lawsuit was about people living in every state that had been affected by smoking, whether it was chronic obstructive lung disease, cardiovascular disease, any number of things. And so Mississippi led the effort to sue the tobacco companies for the negligence or for their responsibility for the health of people who had used their products. And so the lawsuit ended in these 46 states receiving annually, using a methodology, dollars that would be used in their state. But it was interesting because the law itself, or the settlement itself, did not say it had to be used for health. And Arkansas continues to be the only state that uses all of its money for health. We receive about $56 million annually. That fluctuates. The methodology they use, we're not real clear, but it has something to do with people buying tobacco products, and you would think as the tobacco product buyers decrease in numbers, which they are some, but not to the point we would like, that it would have to be used on health. But every state got to decide how they were going to use their funds. Arkansas had a governor at the time, Governor Huckabee, and I'm sure you all have heard of him because he ran for president, and he was here in Iowa on several occasions. And he had just gone through a real healthy change in his lifestyle. He had been quite overweight, and so he went on a diet, began running, and he has run in a couple of marathons, maybe more than 2, I know of 2. And so he decided that when these dollars came to the state, he wanted them dedicated to health so that Arkansans' health would be better. And with that, he tried to get it through the legislature. The Senate passed it, the House wouldn't. And so then he took it to the people, and through a referendum of 67% of Arkansans, we decided to use that money for health. There are 7 programs, and we're one of the 7 programs, the Arkansas Aging Initiative, the only one targeting older adults. We receive anywhere from $1.5 to $2 million annually for this program, and we have leveraged to date over $8 million. We now, I see 8 on here, we really now have 9 regional centers on aging, and each center provides clinical care, it's primary care, and we use an interdisciplinary team, a geriatrician, advanced practice nurse, and social worker to provide geriatric specialty care, and we also provide education. Our vision is to be a leader in improving health of rural America, so that's in part where we have some kin, if you will, to Iowa, because being rural, both states are rural, and both of us have a lot of older adults. We're both in the top 10 in terms of per capita, and both states are expected to stay in the top 10, even get closer to the top in terms of older adults. We also have a mission to improve the health of older Arkansans through geriatric care, innovative education programs, and influencing policy. Our overarching theme is consumer and community engagement, and that is that we are not paternalistic in our approach, but we believe that we need to engage the community in helping us design the best systems of care and to provide the best care. And we also believe that ultimately the individual who is receiving our care is responsible for their own health care, and we help them to assume that. We also focus on delivering what we call evidence-based information. That means that we look at what the latest research says about any particular problem that we are going to talk with the community about or with older adults. And we focus on better quality of care, better quality through better educated providers, leading us to an expert geriatric workforce. And we do know that the way that we provide this care does lower cost, and I'll talk about that a little bit later. This is a map of the state of Arkansas, and you see all the regions that we have. I want to share with you that 7 of these are funded by the Master Tobacco Settlement. We knew we could not, with the funding, do more than that. But you see the little brown area there called Oaklawn Center on Aging. It's located in a town called Hot Springs, and in Hot Springs we have a racetrack. And the racetrack is owned by the Sella family that lives in St. Louis. But the Sella family wanted to put games, video games of skill at their racetrack. Now, we don't do gambling in Arkansas, but video games of skill. And so they could only do that if the citizens of Hot Springs voted that they could do that. So they put out a carrot to entice the vote. And the carrot was that they would start $1 million foundation, $500,000 to create a center on aging, and $500,000 to students in their school district to go to college. And so by about 8 votes, it was passed. And so they created the foundation. They also said that they would give 0.5% of the proceeds from gaming video skill to the Center on Aging in perpetuity. So we have a Center on Aging funded by gambling. And we have tobacco funding the other 7. And so now we are waiting for the opportunity for alcohol tax, and we will have all the major devices. But it doesn't matter. We want to take care of older people, and money could be good. Our 9th center just recently came on board, and it is funded by the hospital in the county called Baxter County. And they, in that county, 29% of older adults are 65 and older. We have lots of retirees from Illinois, from Wisconsin, from Minnesota, from Iowa, who choose to come and live their retirement years in that beautiful part of the state. And they have supported creating that Center on Aging. One family has left all their assets to that program for the education part. Another family gave $1 million to renovate a little house for for clinical care. And so the community has really become an active part. And they also have a huge volunteer group that works with them. As I talk today, one of the things that the Centers on Aging, all 9 of them, are addressing are caregiving, and that's both family and paid caregiver across long-term care settings, and chronic disease prevention and management. We know that this country spends billions of dollars every year on chronic disease, and that with a lot of effort that we can prevent some of those chronic diseases from happening. And why is that so important right now? Every day, 10,000 people are turning 65 and older. The baby boom generation born between 1946 and 1963 are going to push this country in a way that we've not been pushed with how we're going to care for older adults. And I think it is critical that we try to have a healthier population as we get into aging, but also as we age. So if you think about some of these statistics, more than 1 in every 8 persons today is an older adult. By 2020, 6.6 million people will be age 85 or older. And why is that important? Because the older we get, and especially in the 80s and older, that is the population that tends to be more frail and need more assistance. And so therefore, the impact that it is beginning to make on, do we have enough healthcare providers to take care of what we're doing? By 2030, 1 in 5 people will be age 65 or older, and about 70% of individuals over 65 will require at least some type of long-term care services. And by long-term care services, I'm talking about nursing home, assisted living, hospice, in-home care, rehabilitation. Those are some of the main ones that we have for long-term care. So it's really important that we begin to look at how are we going to have a workforce that can take care of people across this continuum. So we're going to see every state, and I had the opportunity to talk with some students in the College of Public Health and their faculty, and I asked them, is Iowa rebalancing, what we call rebalancing long-term care? Arkansas is working very heavily on that, and the Affordable Care Act, the healthcare reform, has really pushed states into addressing issues, especially related to Medicaid. Medicaid being the insurance, if you will, for individuals at a certain level of poverty. In Arkansas, someone on Medicaid, for every dollar we spend as a state for that individual, the federal government gives $3. When you look at the Medicaid pie, almost half of that Medicaid pie goes to care for people in nursing homes. And what Arkansas is addressing is the nursing home the most appropriate place for all the individuals who are in the nursing home, or can we move some out of the nursing home and care for them in the community? And so it's a shifting of dollars. If we use some of those Medicaid dollars that we use in nursing homes and shift it to community, we know that community care is costs less. But then you get into situations where care in the community, the clear majority of care of older adult who lives in the community is by the family, 80–90% of the care. And so then we're beginning to talk about what is, how does that affect families, especially their children, for instance, who are working, or their children who have children. So it's something that we as a state are really taking a hard look at. How are we best going to do it? If we had paid assistance in the home, it is less costly than nursing home. But here's something that most people don't realize. In nursing homes, where we have certified nursing assistants, any nursing assistant has to be certified to take care of someone in the nursing home. In Arkansas, they have to take at least 90 hours, and that does include 15 hours of dementia. The federal government says it has to be 75 hours. They don't have a mandate on dementia. So we as a state went over and beyond that. But for assistance to care for individuals in the home, they don't have to have any training. And most of them will have on-the-job training by the agency that they work for. They will, and so we don't have any standard. We don't require those individuals to really know what you would expect them to know. And most families think that when they have an in-home assistant, they have been trained to take care of them and know what they're doing. And so as a country, do we need to really do something about in-home assistance in terms of what kind of education do they need? Because unlike in a nursing home where you have others who can help support you, when that in-home assistant goes into the home, there's nobody. And so what kind of education and preparation do we think those individuals need? And I think, and I'm going to get into a program in a minute that we're doing, but as a country, we need to really address that if we're going to be providing more care in the home so that we have a good prepared workforce. So for every person in the nursing home who needs assistance with 3 or more ADLs, that's activities of daily living, such as feeding self or dressing self, there are 1.83 people living in the community who have the same level of disability. And then only 7.5% of people 75 and older live in nursing facilities. So the clear majority of older adults are already living in the home. And most older adults I've talked to don't tell me I can hardly wait till I go to a nursing home or I can hardly wait till I go to assisted living even. I want to stay in my home for as long as I can. I want to take care of myself for as long as I can. And so if we do more work on chronic illness, chronic disease, then we will help individuals stay where they prefer to stay. 78% of caregivers, and this is family caregivers, say they needed help or information. And isn't it amazing that for people living in the community that 80–90% of the care that person receives is from family? And what have we done to help the family know how to care for them? What have we done to help the family know this person is bedbound but can get up in a chair twice a day? Have we taught them how to get that person up and into a chair so they don't injure themselves or the person they're trying to get up? So it's a matter of what kind of preparation, what kind of education, not only for the paid in-home assistants, but also for the family caregiver. The demand for professional home workers is increasing, and this is expected to be the #1 job that is needed in the country in a very short period of time. You can see by this last one, by 2016, the Bureau of Labor Statistics said we need 1 million direct care positions, and that's the in-home assistant. Let's see, I think I've said most of this. 7 in 10 family caregivers are caring for someone 50 years of age or older. 7 out of every 10 family caregivers are employed. Now this is also a problem, and it's a problem for employers in that many individuals working have older parents and they have children. We call that the sandwich generation. What do they do? Care for the older loved one? What do they do with the children? So they're really stretched and tension there. We also know that one of the major problems in businesses is that individuals have tried to care for their older loved one all night long, and then they try to work, and then they go home, and that cycle is repeated. And so they have an employee who is tired, giving less, and really needing how can that individual be helped. Many of employee assistant programs do not have programs in place that will help their employees, either knowing about aging, knowing about caregiving, or helping them try to figure out what kind of system do they need in place to help them be successful in caring for their loved one as well as children. I'm going to skip that one. We have developed at one of our centers on aging in Northwest Arkansas the Schmeeding Home Caregiving Training. It's named after a man, Lawrence Schmeeding, and I had the privilege of knowing him. He died about 3 years ago, and he started out as a truck driver, and he lives in Northwest Arkansas. When he gave us the first call, not about this program, but about wanting a center on aging in Northwest Arkansas, we didn't know who he was. But after some investigation, we found out that he is one of the country's top brokers in potatoes. And he, every year, for a number of years, would leave Northwest Arkansas and go to Alabama so that he would be closer to when the potatoes started harvesting in Florida, southern Florida, and then it moved on up, of course, to Idaho and so forth. But through his generosity, we were able to create the Schmeeding Center in Northwest Arkansas, which was actually the first center in the Arkansas Aging Initiative. And he dedicated over $15 million over a 20-year period, plus about a 55,000 square foot facility to house the clinical and education components. But what he was most interested in was a caregiving program that would train, prepare in-home caregivers. He had a brother who had Alzheimer's disease, and he promised his brother he would keep him at home. And here's a man with unlimited resources, and he could not find people who would come and work who knew what they were doing. And so he just went through them one after another. His brother did die, but one of the things that he wanted was to create a caregiver training. And so we have created this program. It has about 115 hours in it, and it has 4 levels. And I'm going to talk about those 4 levels. The first is what we call Elder Pal. It's 25 hours, and it is about aging, and it is helping someone to get at least some basic information about older adults. Usually those individuals would be sitters in a home, and they wouldn't be engaged in a lot of some of the personal care. The personal care assistant is what we see in many area agencies on aging that have personal care offered to older adults, and they are able to bathe someone, transport someone from bed to chair, and so that education takes about 25 hours. Then the home care assistant, and what we have in terms of a place where these individuals learn how to care for someone in the home is what we call a care house. And we have built a little bedroom, bathroom, living room, and kitchen. And we do all the training in that area so that individuals get used to tiny spaces and how to have a real bed and how to get someone out of the real bed. And then we have 16 hours in Alzheimer's and dementia. So when someone finishes all 4 of those, they can sit for the Certified Nursing Assistant certification. They don't have to, but they can. And most of our graduates have sat for it, and most of our graduates have successfully completed that. so that they can proudly tell someone that they go to work for, I am a Schneiding trained in-home caregiver. And then people are beginning to understand what that means. We also have a program for family caregiving, and we have, and I'm sorry I didn't put down how many hours, but we do have people who are caring for family members that can come to this program and learn how to be better at caring for their loved one, and that is one of our most sought after programs. What we've been able to do in Arkansas is the Donald W. Reynolds Foundation out of Las Vegas, Nevada, was founded by Donald W. Reynolds, and he was an individual who had holdings in Nevada, Oklahoma, and Arkansas. Most all of their money is in those 3 states that they have awarded, and they became very interested in the Schneiding caregiving program. So they have thus far committed $11 million to the Arkansas Aging Initiative, and we are replicating the caregiver training program in 8 sites around the state. We opened our last site at the end of this month. And so we will have individuals throughout the state will have access to this kind of training, as well as caregivers. Every one of them have a little care house, and without the Reynolds Foundation, we would not have been able to do it. But our classes are full in every one of our sites, and we're trying to figure out how we can, quote, bill for the education, because unlike certified nursing assistants where they get to bill, there is no way to bill, and so individuals have to pay $100 to be a part of it. We do have some scholarships, but not a whole lot. But that is a way that we can say to the state of Arkansas, anyone who has come through any one of these training sites then has that certain level of education. And we're hoping that through the leadership of the Schneiding Center that we will be able to take that across into other states. And actually, the Schneiding Center does have this program in Texas, California, and Hawaii. And they're doing something real interesting, and it's called micro-lending. They had a pot of money that they started with, and they were able to make loans to individuals who wanted this kind of training. Then when the individuals started working, then they started paying back the loans, so that pot of money is there most of the time for individuals. It's kind of like paying it forward, and but yet it keeps getting replenished from individuals who have taken that loan. That is a model that's being used in a number of undeveloped countries to try to get better education for individuals. So chronic condition, any illness that lasts a long time, it's irreversible in most instances, but not all. 8 out of 10 people age 65 and older have a chronic illness. We spend, and this number is staggering when you think about it, in 2007, we spent over $430 billion on chronic care. And it's expected by 2018 to be over $900 billion. And when we really put that in context, and when we think about a chronic illness, and that chronic illnesses can be prevented, that chronic illnesses can be managed, and that we can stop the progression of chronic illnesses, not all of them, but some of them. Many chronic illnesses come about because of the lifestyle choices we as individuals have made. So it is really important to society that we begin to take a look at what is our responsibility to ourselves, but also to the bigger picture of having the healthiest lifestyle possible. See, I just went over those numbers. One of the chronic illnesses is diagnosed diabetes. And you can see in 1994, it was prevalent. And you know, I live in the South, and I can tell you that many of the problems are in the South in terms of chronic illnesses. And one thing I was sharing earlier today that to me is still staggering when I think about it in Arkansas. If you look at our state, and we have the eastern border that's on the Mississippi River, and then we have the western border that goes up against Oklahoma. And people who live on the eastern border in the Delta have a 10-year less life expectancy than those who live in Northwest Arkansas. Now, Northwest Arkansas is home to Walmart, to Tyson, to J.B. Hunt, other groups. Most of them in Northwest Arkansas have a baccalaureate degree or higher. Most of them living in the Delta do not have a high school degree. And it is very, very clear the association between education and health. So goes education, so goes the economy, so goes health. And so it is really critical to start with education, at least for our state, and to do a much better job. Diabetes in our state is very high in the Delta. And why is that so? We have a high number of African Americans, and we find that the incidence of diabetes in African Americans is greater. You can see in 2010 the change, and you can see across again the southeastern part. And it's interesting to me how this goes up to Indiana and Ohio, you know, up through that area, and it did that in both years. But anyway, that is a disease that is becoming more prevalent, sometimes associated to obesity, sometimes associated to genetic factors or whatever. What we're doing in the Arkansas Aging Initiative is we have now 22 master trainers in the state through our Arkansas Aging Initiative that took the Stanford Model Chronic Disease Self-Management. It is research-based, evidence-based, and it is working with individuals to how to take care of themselves if you have a chronic disease. And they unfortunately only have two parts right now to this, and one is generally how do you live with a chronic disease, and the other is how do you live with diabetes. And so we are using this program with individuals with chronic disease and are having some degree of success, but the problem has been trying to get people to enroll in it. And one of the things we have found out, it's a 6-week program. They go, you know, like half a day a week or something like that. But to engage people to do 6 weeks of this program has been very hard. We have not had the number of completers that we would like to have had, and we attribute that to over a period of time, people don't want to do that, make that kind of commitment. Just a little bit, self-management is defined as provision of education and supportive interventions. It is getting the individual to assume responsibility for their own care. It's what we do and don't do for ourselves that is going to make us successful. The 6 workshops, these are the 6 topics: reduce fatigue, pain, and frustration. And why is that so important? When we're tired, what do? We tend to let barriers down, or we tend to fall into bad habits because we're not at the top of our game. And so we really spend a lot of time talking about that. there are two things that are really, really important to health and chronic disease, and that's exercise and nutrition. And exercise is about aerobics. Exercise is about strength building, because we know that as we age, that muscle, if we don't strengthen muscle, it will turn to fat. And so how important that is. And then also flexibility. And so medication usage is one of the things, communication, and then as I mentioned, nutrition. I guess at this point, one of the last things that I want to talk about with that is behavior modification. And that is, and I would like to hear from y'all in a little bit, but as we get older, is it more difficult to change our behavior from what we've been doing all of our life? And it's so much easier to just say, well, I've always done it that way, and to continue doing that way. And this is one of the key techniques, and that is, and I think about smokers, but I can also think about people who are overweight. And you know, if you smoke, that it's bad. You know that it's going to affect your lungs. We've got the information out there, but yet people do it. We know that exercise and nutrition are important, and it's not just nutrition, grab a bag of chips or whatever. It is nutrition in terms of vegetables and fruit. Why aren't we doing it? Or exercise. It doesn't take 30 minutes to go 2 miles. And if you just did that 3 days a week, why are we not doing it? And so it is really engaging and trying to get beyond that, or helping people get motivated to do, because if we were to do, let's say, flexibility, then we can get up out of the chair without rocking a few times before we get up out of the chair. It is maximizing what we can do for ourselves. So it is, so far nobody's really cracked this motivation piece to any great extent, but it is what motivates someone or ourselves to do anything. So I think, that's really important. The Arkansas Aging Initiative, and I'm going to close with this, the Arkansas Aging Initiative, to me, is a model that we can use in other states. We are replicating it now in Oklahoma. The Donald W. Reynolds Foundation is funding that replication. They are going to have 5 centers on aging. What we have found, as we have developed each of our centers, the hospital is the best partner that we have, because the hospital owns and operates the clinic, and they agreed to hire the team. When we went around the state and we asked 7 hospitals to engage with us in this, and oh, by the way, will you pay for it? Will you pay for the team? Will you operate it? And all 7 said yes, because they knew that the number of older adults in the state needed care. They needed ambulatory care. They also saw it as an opportunity that they would be a pipeline into their hospitals. Hospitals like Medicare dollars. You may hear grumbling about it, but I can tell you hospitals like Medicare dollars. The clinic is paid through Medicare dollars, and in our clinic we have an hour for new patients and 30 minutes for return. And most private practices, you do good to get 12 or 15 minutes. And we didn't think those clinics would make money, that it would be, the loss would be recouped with the downstream revenue to the hospital, with the downstream revenue being x-rays, PT, ER visits, hospitalizations. But these clinics do make money, and the hospital still gets the downstream revenue. We have figured it out that for every dollar generated in the clinic, it generates $22 for the hospital. So it is a good source of income. At the same time, it is addressing needs of older adults. The team that we assemble in each one, Arkansas has the highest per capita of geriatricians highest geriatricians than about any other state in the country. We've been successful in recruiting geriatricians because they like the affiliation with the University of Arkansas for medical sciences, but they also like to practice in the community the way that they were taught to practice. We have geriatric nurse practitioners in almost every one of our clinics as well. We also practice in nursing homes and in the home. And so it's a model that I think really needs to look at. We know that in 6 of our centers where we conducted a study, we had the College of Public Health conduct the study, that we had 1 to 4 avoidable hospitalizations compared to other primary care practices. And that reduces cost. We also know that in 3 of our sites where they have been tracking the care given by geriatricians, that the length of stay in the hospital is less than any other primary care physician. And they know how to, when is the right time for discharge, but also does that individual continue to need help so that we can get the support system, or that they can be admitted, say, to a nursing home for a period of time until they do get stronger. And so we know about that infrastructure better than most other settings. So from a cost perspective, we have seen some good indication that it is saving money to society. So, and we know that health outcomes have been improved because of the care given in these clinics. So with that, I would like to open the floor for any questions anyone might have.
I have a question about the economics, like the certification of CNAs. Is that reflected in what their wages are improved or no?
No,
Can you repeat the question?
Okay. Sorry, the question was for the certified nursing assistants having the certification, does that reflect in their wages? And my answer was no, because in order to provide care in the nursing home, they have to have that certification. So the nursing home, in a lot of instances, will put that person on salary while they're doing the certification preparation and exam, but they get the base salary, which is usually minimum wage.
Thank you.
Mm-hmm.
Claudia, I
Yes.
wondered if you might, what is the statistic in terms of the availability or accessibility of healthcare for elders in Arkansas compared to other states? You were talking earlier that 98%.
Right now, because of all of our centers on aging, 98% of our Kansans are within 60 miles of interdisciplinary geriatric health care. And, you think, well, who's going to travel 60 miles to receive care? Sometimes people won't, but sometimes when there's multiple problems going on and they're complex and they haven't been solved, that it is not uncommon for family and that their loved one to come to a clinic visit for consultation. What can we do in this situation? And help that primary care practitioner 45 miles away in addressing the problem. So, and we're also beginning use of telehealth, where we can connect from our centers to University of Arkansas medical scientists, say, with a rheumatologist or a neurologist that they don't have in one of the smaller towns, as well as our centers connecting with some of the smaller hospitals and nursing homes that don't have expertise in the field of geriatrics. So we're using that methodology and will increase the use of that so that we can extend geriatric specialty care and also other subspecialties.
You mentioned your geriatric interdisciplinary team had a geriatrician, an advanced nurse practitioner, and also a social worker. Do you guys typically also involve the pharmacist?
That's a good question. I do not know yet why pharmacists cannot bill for services, but it's a discipline that cannot. But we, at the University of Arkansas Medical Sciences, where we do have one of these clinics, we do have a full-time pharmacist, and we think that is absolutely essential. I mean, what is the big problem with older adults is polypharmacy, and we always work to reduce to the minimum number of medications someone needs. We don't have pharmacists all over the state, and part of it depends on whether the hospital has the money, you know, and a couple of them do have a part-time pharmacist. We also try to have nutrition involved in some way. And 2 or 3 of our centers have neuropsychologists that do all the memory testing for that center. And I think that's an important discipline as well. So thanks for that question.
Another question, do you know, with the master tobacco settlement, did Iowa get any of those funds? And if so, how does the state of Iowa distribute them?
I don't know the answer to that.
Okay.
I know Tennessee got some, and they used it all on highways and budget deficit.
Smoking cessation classes is one of the things that was done.
You would think that that would have been mandated in the settlement, but smoking cessation wasn't, or even saying it needs to be spent on health, because that was the whole reason for the lawsuit, is that so many people, especially through Medicaid, were being cared for because of smoking-related illness. But they did not say that. And so every state has used it differently, except Arkansas has always used it for health. So I'm bragging on our state.
Can I ask one more question? So obviously your background is nursing. As you look forward to the workforce needs, do you see nursing as being the primary one to step up and supply those? Do you see it as being the families, like you mentioned the sandwich? Are those family members really going to start to get the support from their employers or wherever they need it to be those people? Or do you even think it's going to be the geriatricians? I mean, they've talked about geriatrician shortage forever, and let's face it, we're not going to catch up quick enough, you know? What do you think?
I think it's going to take multiple disciplines to do it. This is not one thing that nursing can do, you know, by themselves. I think that we really need to be working with employers to help them with helping their workforce be better prepared to care for an older adult, to know more about what goes into it. And I think through employee assistance programs, we could be doing a much better job than what we are. I think in a lot of ways, because nursing is one of the disciplines that is there 24/7, such as nursing homes or hospitals, that nursing is going to be a big part of solving the problem. We've just got to get nursing more to the table and being a part of designing care delivery models that are going to be most helpful. Support families. You know, one of the reasons that individuals are admitted to nursing homes prematurely is because families burn out. And they burn out because nobody is working with them to help put the right support or infrastructure in place so that they would be successful. If we would concentrate on getting that better infrastructure in place, and it might be that, say, nursing homes, as they downsize, can they turn it into an adult daycare, or can they turn a part of it into respite care, where families can say, I need to have some time off, I'm going to be gone this weekend, and that we care for that person in that type of environment. Individuals who have loved ones that have Alzheimer's or other kinds of cognitive impairment need a lot of help because they don't get much sleep because of the individual that they're trying to care for. And we are going to have to help. I think we're just going to have to get back to being more focused on how can we help each other and bringing people who have that commitment to try to solve that issue.
You know, as you talked, I was struck by how you've gotten different pots of money from different donors, or it seems like you're especially good at getting partnerships going. So do these things just fall in your lap, or what do you do to?
They don't fall in your lap.
Oh.
I am very happy to say that the Arkansas Aging Initiative has over 700 partners statewide. And that is because from the very beginning, our philosophy has been inclusion. And it has been being good stewards of the money that we have. And we could easily go out and be a silo and maybe duplicate what the area agency is doing. But why do that? Why not together, if we came together, maximize the dollars that they have and that we have and use those dollars in a much better way? And to that end, most of our partners are small nonprofit organizations. They don't have a lot of money either, but we can help extend what they do, and they can help us access people that we maybe wouldn't have gotten to it, without their help. So it's been more a philosophy along our way. In terms of funding, we in Arkansas have been very fortunate to have the Donald W. Reynolds Foundation. I was a part of when the Donald W. Reynolds Institute on Aging was started they started funding in 1997 with $28.8 million. They built a beautiful facility. We used $18.3 million of that. They've now added another 4 floors. All told, that foundation has given over $80 million to Arkansas, and to the University of Arkansas for Medical Sciences, to aging. And there's no question, money attracts money. And just like in academia, if you have a new building, you're going to be able to recruit people because people like to work in a new building. And so we have been clear about the mission, I guess, and we have been good stewards of the Reynolds Foundation money, but the Hartford money as well. I think one of the reasons that we became one of the 5 Hartford centers is that we were sitting in that new building. It was, at that time, we had just moved in about a year and a half before that, and we were very interdisciplinary in our approach. And so I think we have brought some kinds of unique things like that. Plus, they like us. Any other questions? Well, thank you all so much for being here.
Thank you.
And if I'm available afterwards for a little bit, and I really enjoyed spending this time with y'all.
Thank you.